Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global P.A.D. Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global P.A.D. Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the Heart of Innovation. Today, we are excited to introduce you to the physician who has earned the prestigious Global Vascular Luminary Award in the Global P.A.D. Impact Awards. P.A.D., or Peripheral Artery Disease, is defined by restricted blood flow in mainly the leg arteries, causing debilitating leg pain, leg cramps, neuropathy, and non-healing wounds on the foot or the toes. It impacts more than 230 million people worldwide, which is why having a doctor who is dedicated to improving care with a profound impact on education, advocacy, and research is so important to highlight. The Vascular Luminary of the Year Award specifically honors a doctor whose impactful research, policy change, and advocacy are truly transforming P.A.D. care around the world. So join us as we celebrate this remarkable individual's dedication to creating the change that we all want to see in life and limb-saving facilities across the globe. But guess what? I'm not going to tell you who it is yet. You gotta stay tuned to discover who has made such a significant impact in the fight against P.A.D. But first, I gotta bring in my co-host because we gotta do it together, Dr. John.
Hey, Kim, how are you? Happy Saturday.
Happy Saturday. I hear you've been out at football games today.
Yep, we had freshman football. We lost, but that's okay.
Oh, no.
It is what it is, right? You've got a young team, and they're trying to get to know each other, and it was a little bit of a struggle, but I feel like they'll get there. It was a beautiful day, 55 and sunny. You can't ask for much more than that. And plus, last week I was on call, and we did the show from the hospital, so I'm glad to be able to do it from home.
That was such a smart show, having your nurse practitioner in there and having a moment where you're on call. And in that moment, while we are live, both of you together are literally, tangibly saving the piggies of a patient, rallying your entire team at Ohio Health to come in on a holiday weekend to save one person's piggies. And it was amazing. It was such a great show. If anyone missed that show, you gotta actually go back and watch it. It is on YouTube, youtube.com/The Weight of My Heart. Check out that show because it was powerful, literally.
Yeah, and I just texted our podiatrist who was taking care of that patient. The patient actually had to go back to the operating room to do some debridement. The surgical incision that they had formed was starting to fail. But I got some positive news because she was able to remove some of the tissue that was dying, and there's healthy tissue and there's some bleeding, so that's good. So hopefully the patient will be able to leave our hospital with her leg. She's had a minor amputation below the ankle, but nothing major. And as you know, and as we've talked about, that is a huge differentiator between someone living longer and not. I mean, it's unfortunate the high percentage of people that get a major amputation that don't leave the hospital and end up dying. And so these folks are very sick. So we want to do everything we can to preserve her leg.
And I think that's such a beautiful, thank you so much for the update. And if that is not the most beautiful moment of inspiration, I am sure Dr. John has something else that is.
Dr. John Phillips' spectacular vascular moment of inspiration.
So I don't want to give away the physician who won the award, and therefore I can't make a comment about why I picked this particular statement. But I've been reading Meditations by Marcus Aurelius, the Roman Empire, and I found a statement that he made that I personally try to get better at doing. And so he said, and this is in translation, but it's translated as some people, when they do someone a favor, are always looking for a chance to call it in. And some aren't, but they're still aware of it, still regard it as a debt. But others don't even do that. They're like a vine that produces grapes without looking for anything in return. And I think I like that because a lot of us, yes, we do things and we try to pay it forward, but sometimes I find myself asking for, well, what are they going to do for me? And I think this is a nice reminder of just doing the right thing, letting it go, and keep doing the right thing, and don't expect anything in return.
It's hard for me to imagine because just in the story we were just telling you about saving the piggies, what was in it for you? Absolutely nothing except to save this piggy. So I think everyone would agree with me that you're quite selfless. So it would be hard to believe that you'd be expecting anything in return.
Well, I mean, and Kim, same for you, obviously, the phone calls that you get in the middle of the night and dealing with folks who have very debilitating illnesses. You mentioned the 230 million people worldwide. About 7 million worldwide have critical limb ischemia, which these are the people that are at the highest risk for amputation and high risk for death in the next couple of years. So we're all in the fight together, and I'm glad you're having these awards. It's P.A.D. Awareness Month, so I'm really looking forward to finding out who the Vascular Luminary of the Year is and having a conversation with he or she.
I think it's the perfect moment, and I think it's the perfect quote that truly it represents this individual who is truly selfless and goes above and beyond in so many ways beyond the clinic, trying to advocate for these patients at the highest level, of government even, and to help improve the quality of life and care for these patients. So our 2024 Vascular Luminary of the Year is Dr. Oh my goodness, I just was gonna Athanasios, Saratzis from England, Leicester. I just am so in awe of you and everything that you have accomplished and continue to do for patients. And thank you so much for being here on a Saturday night so that we can announce the award and interview you about your amazing impact on patients across the globe.
Well, thank you very much for the invite and for your very, very kind words, really. We are a bit more reserved in Europe and especially in England. So, yeah, I really appreciate the invitation and the award. Yeah.
Where does your passion for PAD in particular, as a professor of vascular surgery, I mean, you could be focusing on so many aspects of vascular disease, but why PAD?
It's probably by far the most complex of vascular diseases to address because these individuals have got a number of medical issues, and then the anatomy of their problems, if you like, is quite complex as well. So it is quite a challenge for us clinically and surgically. And of course, the other thing is that, well, you wouldn't be doing what you're doing if people with PAD or peripheral artery disease were getting the right treatment at the right time, correct? So again, that's another drive behind what our whole team is doing. And I don't view this as a personal award, if you like. It's for the whole team of people that have been doing the research and the clinical work for a number of years, both in Leicester, where I'm based, as well as nationally in England.
And coming up right here
Yeah.
on Heart of Innovation, we're going to hear more about this research and his advocacy efforts. So stay right here on the Heart of Innovation. Don't go away. How is the pain and the cramping that you get with PAD different than an athlete? Let's say when you're a teen, you get a muscle cramp in your leg and you need to stop to rest or else you will hurt yourself, versus with PAD, you get that cramp and you're not to stop because it's a good thing and it will actually help you to improve circulation to walk through it.
So there's two physiological processes going on. Take the athlete, okay? The athlete that you speak of running track meets gets a huge Charlie horse in their leg. Whoa, has to stop. Typically, in that situation, what's going on is that they may be electrolyte imbalanced. So they're not getting enough potassium or sodium, and they get a cramp because of that. Because the way muscles work, muscles are pretty stupid. They really can just contract and expand. And so when you have a situation where you have not enough electrolytes to make that actual movement, that can result in a tightening and a cramping of the muscle that is very painful. And if you don't let it just relax and open out again, you can actually rip the muscle off of the area it needs to be. So you don't want to do that. Now, that's not our situation. In our situation, the P.A.D. patient that's walking and getting cramping, that's a totally different question. What's going on there is lactic acid buildup. So let me explain. Imagine that you're at the gym and you're doing a bunch of bicep curls, okay? You do 1, you do 4, you do 30, no big deal. Now you get to 35. Oh, it hurts, right? The bicep hurts. What does your trainer always say to do? Do 2, give me 2 more, give me 2 more. Why? Because if you're trying to build muscle, if you're trying to get those biceps huge, you need to do those extra 2 because that's when all the work is happening. Up until 37, you were just flying. It's no big deal. But it's those last couple, give me those extra 2. That's where you build the muscle because you break it down and you rebuild it. But that pain that you're feeling, that's lactic acid buildup. And you want the blood to come in and wash it away. So when you're walking and you have PAD, kind of the same thing is going on. You get a buildup of lactic acid in your legs and that crampy pain because not enough blood flow is getting to the calf to wash out all of the stuff that the cells are making to allow you to go back to a natural state. So similar to the bicep curls, if you're walking and now your leg starts to hurt, you need to do that, oh, give me that extra minute, because that's when you're going to be building those collaterals. The best way to put it, the way that I put it with my patients is I want you to think of the county that you live in, okay? All of you think of the houses that you're in. Imagine if you have a terrible road right outside your house. It's got a big pothole in it. And the city only has a certain amount of money to go and fix potholes in the state. Who's going to get that pothole fixed? I'll tell you. It's the person who's going to go down to City Hall and scream about it. That's the person who's going to get it fixed. So the same way, your body has a certain amount of energy, of nutrients, of stuff that it can go fixing things around your body. So the only way that your legs are going to get the attention of the rest of your body to allow it to come and build those collaterals is by screaming about it to the body. And how do you scream about it? You make it be in pain when you walk. So when you're walking, you're causing that pain. Your body's not going to like that. First day, it's going to be like, ooh, we don't like that. Second day, ooh. Third day, let's lay down some collaterals so that we stop this screaming. And that's the way. But if you just sit in bed or if you just sit on the couch all day long and you don't actually walk, the body's going to think, well, this person isn't even using this. We're not going to waste money fixing a pothole on a road no one's even driving on. That would be silly. And that's how, quote unquote, if you don't use it, you lose it.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. Let's get right into the heart of the interview. We have Dr. Athanasios Saratzis, a vascular surgeon out of the UK. So, Athanasios, tell me a little bit about what do you do? Like, you're obviously a vascular surgeon. How much time do you spend doing research, and whether it's clinical or benchtop, and how much time do you spend working with patients, whether it's surgically or endovascularly?
Yeah, thank you for the question. So I'm an academic surgeon, and I've been a professor for probably, two years now. And I would say I spend about 60% of my time delivering research at present, which is mostly randomized controlled trials, as well as some projects where we're trying to develop interventions for people with vascular diseases so that we can improve all aspects of their healthcare. But still, I'm very active clinically. So I do operate quite a few times a week. I run my clinics, etc. So I'm an active surgeon, but I would say the bulk of what I've been doing in recent years involves trials or things like building complex clinical interventions for people with vascular problems.
Can you give our listeners and myself and Kim an example of some of our randomized controlled trials you're involved in right now?
Probably the biggest one that we've opened in the last few months. It's been open for about 8 months now. Is called the VOC. If you follow someone like myself or the Leicester department on things like Facebook and Twitter, X, etc., you might have seen it if you've got an interest in P.A.D. So what we're trying to do in this big randomized controlled trial, we're trying to look at whether keyhole procedures or open surgery are better for treating blockages of the aorta and the iliac arteries. These are the main arteries in your tummy and the main arteries in your pelvis, really going down to your legs. And then I'm about to open another randomized controlled trial looking at different types of dye that you can give to someone when they have an angiogram or an angioplasty to protect their kidneys. So we'll be checking whether CO2 or the usual dye is better for people who have got low kidney function. That's about to open in October. These are two examples of randomized studies, but again, I would probably have to spend a few hours talking about all the stuff that we do in terms of creating complex interventions to address all the basics of medical therapy for people with P.A.D.
What do you think your greatest frustration is with current care in England in particular, that you are trying to create the change that we all want to see at the highest policy levels?
Couple of things. Late presentation. So unfortunately, people are not very aware of P.A.D. And when they see their doctor, even their family doctor or GP, as they're called in England and the rest of the United Kingdom, even the family doctor sometimes don't diagnose P.A.D. early enough. So early presentation or late presentation, if you like, that's a major issue. So we need better education both for patients as well as healthcare professionals out there. And then the second thing is, and that's a global problem, right? Mm-hmm. We don't know which treatment is the right treatment for these patients in many scenarios. So I just mentioned the EVOC trial, for example. We don't know whether open surgery is better than these new expensive keyhole procedures for opening up an aorta or an iliac artery, right? And the same goes for pretty much every artery in the body. We just don't have enough evidence yet in order to support decision making.
And when it comes to we know, and we always tell people and through our organization that we always like them to try the keyhole first. But the thing is that to stop, if they end up with a revolving door,
exactly.
Yes, those aortobifemoral bypasses are pretty big procedures. And we actually have doctors here in the US that will, for many patients with multiple comorbidities, will jump straight to an axillary bifemoral bypass, which literally there's no contingency plan afterwards. In England, though, when you ask vascular surgeons there, they're like, oh, no, we don't even go there. That's like palliative care. That's if they're just going to actually need a few months to get their affairs in order, which is interesting. But they're more apt. We find with the aortobifemoral bypasses that we have patients that have had them for like 20 and 30 years. If they can actually sustain, it's a big procedure, right? Big recovery.
Absolutely. So again, we just don't know the answer to what you just explained. We published a big study based on just observational data. That's non-randomized studies about 2 or 3 years ago, showing that the chance of death if you do an aorta bifem about 1%, about 1 to 2%. It's a bit less than that if you do a keyhole procedure. But for the keyhole procedures, like you said earlier, these patients do come back many times for more angioplasties, for more stents, etc. So it's probably not a permanent solution, which is why I think we need to understand that all doctors, all healthcare professionals that treat vascular patients need to randomize patients into these big studies that we're now finally delivering to get the right answers for these questions that you just mentioned.
So do you do this randomization? Is this just within the UK or your hospitals within your region? Is that how that works?
The EVOC study that I just mentioned is across the United Kingdom, all 4 nations, and we're open in 24 sites now, so 24 hospitals now. There are some issues with Brexit, etc. It was a bit easier to do studies across Europe a few years ago. It's a bit different now. It's funded by the NIHR, which is the equivalent of the NIH in the UK. And the NIHR is not very keen to fund studies outside the borders of the UK, but it's a national study in the UK, and we've got funding for 30, that's 30 sites. There's about 2 years of randomization and recruitment left.
Coming up right here on the Heart of Innovation, we'll have more with Dr. Saratzis, so stay with us right here on KDOW. Don't go away.
When I was younger in my career, and I was, my senior partner is a guy by the name of Michael Dake, who's one of the pioneers in the minimally invasive treatment of aortic disease. And I was trying to treat a patient with peripheral arterial disease who had just a narrowing stenosis, calcified and tortuous vessel. And I was struggling to get through. And he walked in the room and he said, Mahmoud, if the contrast and the dye gets through that stenosis, so can you. And then he continued by saying that if there's complete blockage, you know that there was a structure there, and it's still there. You just have to find it. I can't tell you how that little message changed my mindset and approach to these patients. Okay, if there's a structure there, it was there before, it's not there now, but it was there before, there's a path. You just have to find it. But if the dye gets through it, so can you. And that really changed my approach and the success rate. I can't tell you how much more successful I became after that simple, lesson by my senior to me, in terms of, and it just had to do with your confidence level and your mindset. It's a mindset is very important when you approach these patients, like any athlete. If you go in with the expectations to win, more than likely you're going to win. And that was the case. And it reinforces the old adage that every patient is a laboratory. That if you are not successful, obviously this lessons learned should help you on the next patient. And that mentality obviously needs to be there for one to be successful.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Thanks, everybody, for joining us. So during the break, Thanos and I and Kim were kind of just discussing, to some degree, the rationale for what he's trying to do in the UK, which, if I understand it correctly, look at folks that have significant blockages in the aorta and then the branching vessels thereafter in the abdomen, and trying to figure out what's the best way to treat that, whether it's stenting from an endovascular standpoint or surgical bypass. It reminds me, so as an interventional cardiologist, I think we have a pretty good idea of what to do in certain patients based on the diseases, the blockages that they have, the locations in the coronary arteries. We know that surgical bypass actually has a mortality benefit in certain patients, and stenting does it. The issue that we have is patients don't raise their hand and say, hey, cut me open and bypass me. Can't you just put a stent in? I often find that we get that, feeling from patients as well. But I feel like there's certain instances where we have to do bypass because that's the right thing to do. Thanos, are you guys trying to actually get some hard numbers to say that there is a true benefit to doing one over the other? Or I guess what's the primary endpoint in your study?
So again, for this specific study we're discussing called EVOC, the primary endpoint is amputation-free survival. So how long do people live for with their legs on after they've had these procedures? And we're also powered to look at quality of life. So which procedure is better in terms of improving people's quality of life after the procedure has taken place? So these are the two main outcome measures that we're looking at. So it's not just numbers, it's also the perceptions and the quality of life of the patients. And one more thing to mention, this has been designed with patients, and I understand that no one would want to get a massive operation that lasts for 3 or 4 hours, right? But if that operation prevents you from coming back 10 to 15 times to get another endovascular procedure, then that's where we got this message from patients that they would be happy to accept something more invasive at baseline if that's going to improve their quality of life and if that's more likely to make them keep their legs for a longer period of time.
And with those types of bypasses, the one thing that we always coach patients on is, anytime you have a procedure, it's just a matter of when it's going to fail, and some can last longer than others. What is the contingency plan? So do you take into consideration the potential contingency plan when those big bypasses do go down?
Absolutely. And the nature of all of the studies that we're delivering through my team in the NHS and internationally is pragmatic. So we don't select patients based on very strict criteria. We're trying to be very open-minded about who can take part. And then we ask the clinicians to design what they think is the best procedure, both from an endovascular or an open surgical point of view. And we keep mentioning aorta, bifemoral aorta iliac bypasses and these massive procedures. There are much simpler surgical procedures that you can do, like a fem-fem crossover, which is where you join the two femoral arteries together. And these days we can combine the endovascular and the open surgical procedures in what we call hybrid procedures. And again, these procedures are being tested in this EVOC trial that I'm talking about.
Yeah, I'd be curious about that fem-fem. I have not had patients with good experiences with they go down, and if one leg, they mirror each other, and if one leg goes down, both legs go down. We're dealing with that just last week where the patient can't even walk. The doctor relied upon one leg feeding the other, and within 3 months, the other leg went down. And so now both legs are down. So we're trying to get them to get a second opinion and get that blood flow restored sooner rather than later. So I'm curious what the hard numbers will be on that one to help guide us, because we look to the research to find out so we can use it to help guide patients. But I'm curious, what is the role of how important is interdisciplinary collaboration in the research that you're doing, for example, with interventional radiologists, cardiologists, and the like?
If you look at EVOC, there are 21 co-applicants. There's 21 people funded to work on this trial. Mm-hmm. And that includes radiologists, podiatrists, surgeons, etc. If you look at 2 applications that we've just sent in for funding, I think there's about 50 co-applicants on those 2 applications for another 2 randomized trials. And I could not agree more with the people. I keep saying that collaboration is the way forward. I'm very pro collaboration, and there's just no other way in terms of improving outcomes.
Exactly. Well, coming up right here on the Heart of Innovation, we'll have more with Dr. Saratzis, and we're going to hear about what more he is doing to advocate for patients at the highest level and creating the policy change potential that we all want to see to improve care across England. So stay with us right here on KDOW in the Heart of Innovation. Don't go away.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here.
Without a doubt,
we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
So during the break, Thanos, we were discussing that there's a notion that some physicians feel like the first step for a patient in their vascular journey is amputation, primary amputation. You actually, through some funding, did some research and kind of looked at the cost of that as opposed to doing an endovascular procedure or maybe a surgical procedure. And because I think there's the notion that, you just cut the leg off and, it's cheap and quick, it's over with. But clearly obviously that's not what we want for our patients. But if you're just comparing dollars and cents, it sounds like doing that is actually long-term more expensive than trying to open up the artery and preserve the leg for that patient. Is that correct?
Yeah, exactly. There has been this perception amongst surgical circles for a number of years that if you see someone with what we call CLTI, which is when you get ulcers or gangrene in your legs and your feet, or you get rest pain, if you offer an amputation early in the process, then you might be saving some money because the patients don't come back for more revascularization procedures, or they don't need things like dressing changes every few days. As I said, that's been a rather prevalent opinion in certain parts of Europe and probably the States as well. So what we did, we got some funding together from industry and various other partners, and we got data from large parts of England to look at what happens to people with CLTI, that condition with gangrene in their legs, if they've had their leg off, if they've had a primary amputation when they presented to a doctor at a hospital, or if they had a revascularization, so a bypass, an endarterectomy, or a keyhole or an endovascular procedure. And we actually found that if you amputate that leg, you're far more likely to need more dressing changes. You're far more likely to need your GP many more times over the next year after your amputation. And the costs to you as a person, as well as the costs to the healthcare system, are far higher compared to trying to save the leg. And again, that was a novel finding, like you mentioned, and I think it's quite important in terms of convincing people to look at the leg and try and offer some form of revascularization in order to save it.
But when you're with your colleagues, off the record, do you still find that I'm not a surgeon, so for me, I do whatever I can endovascularly, and if I need to, I send for surgery. But do you find that some of your surgical colleagues, despite what you just demonstrated there, still think, let's just cut off the leg?
Absolutely. And changing people's minds doesn't happen overnight, right? But what can I say? I think we're all biased as surgeons and as human beings and clinicians, but somehow we have to start looking at the bigger picture, and that goes for amputations as well as randomizing people into trials and trying to do the right thing for the right patient. We really have to be open-minded a bit more.
What do you think it's going to take, with all of the research that you have done and the data that you show? Everyone always says, well, I'm waiting for the data. Well, here, I have the data. What are you waiting for next? What's your next excuse? Why do you continue to argue for your own limitations, asking for more and more data? Here is the data. When are you going to change, and what is it? What is the catalyst to create that change?
This is a very difficult question, and I would say it's a philosophical question, really. But I think those of us who believe in data, we just need to carry on pushing the envelope, if you like, and carry on funding these big studies, and then disseminating these studies a bit better to patients, because end of the day, the patients make the final decisions. And finally, we need to get through to the decision makers, the policy makers, and that can only be done through hard work, and that's what we are here for. So I urge my colleagues not to give up. Like I said, pushing the envelope. Yeah.
And I, personally, I applaud what you're doing. It's, as a cardiologist and an interventionalist, we know how to treat people with coronary artery disease. We either use the medical management or they get a stent or bypass. But in the vascular space, and then there's only one type of physician, at least in the US, that does that. It's interventional cardiologist. In the vascular space, it's, as we call it out here, kind of the Wild West. You've got surgeons, radiologists, cardiologists, and there's a ton of ways to treat patients. And I think I know what to do, but what I think might not be the same opinion as a colleague of mine.
Yeah.
And you can get away with it. That's what's kind of frustrating to me. I shouldn't say get away with it, but like, it's okay if I put a stent in and it's okay if you do a bypass.
Yeah.
And there's equipoise there, but are we ever going to get to that point where this is the way to treat the patient? Hands down, this is what you do.
I think we can get there. You've described two issues. The one has got to do with the system treating the patients, and that takes people like you and I to create better systems that are more centralized and more unified. And the second thing is creating the evidence in order to make those decisions.
Thank you so much. Dr. Saratzis, we'll have more with him and some final thoughts coming up right here on the Heart of Innovation on KDOW, so don't go away.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
So we only have a few minutes left. Thanos, you mentioned in the break you've got two grant applications pending. One is common femoral artery disease. That's typically, at least in my opinion, a surgical fix. And then the other thing on the agenda was vessel prep. So do you want to share a little bit about what you're doing there with us?
Yeah, absolutely. These are not funded yet, but we've been working very hard on them for about 2 to 3 years now. And it's not just myself, it's my colleagues from St. Thomas's, people like Honeyside, etc. So I'm always very collaborative, and there's a big group of us working together on both of these things that you mentioned. So common femoral artery then, it's the main artery in the groin. There's two treatments. Endarterectomy is the open surgical treatment. It's been around forever. But in the last sort of 5 years, we've had new things like lithotripsy and atherectomy come up, as well as biomimetic stents. And they allow people like, again, you and I, to treat these common femoral arteries with minimally invasive tools. No one has ever compared the surgical option and the endovascular option head-to-head in a randomized trial with appropriate clinical outcomes like amputation-free survival, quality of life, or number of free interventions over the long term. And that's what we're hoping to fund now. We're at the second stage of funding with the NIHR for that one. So hopefully some good news in the new year. And even if we don't get those good news, I'm not the person who gives up. So we'll try and get this funded at some point. And then with vessel preparation, that relates to things like atherectomy or intravascular lithotripsy. So how do you prepare a lesion? How do you prepare a blocked or narrowed artery for the subsequent stretching, the angioplasty or the stenting? Again, lots of new devices in this environment. Most of them are quite expensive, and they've never been compared head to head. people keep saying that they know which vessel preparation device is the best one, but no one has really looked at their effectiveness when we're talking about amputation-free survival and reinterventions, etc. So that's the second thing we want to do now.
So we've got about 90 seconds left. Is cost a huge driver for you? Meaning, if I've got something that'll cost me $100 that I can treat the patient with, or $1,000, are you using $100 9 times out of 10, or how does that work in the UK?
The UK, we've got a national healthcare system. Cost is an issue, so we do look at costs before we offer people procedures, but we've got access to the vast majority of the endovascular equipment that's available out there. And I think we're a few years ahead compared to some sites in the USA and other parts of the Western world. All patients get access to whatever endovascular treatment is out there if we think that we can save that leg. And the final thing to say about cost, we just published a paper with my colleagues from Germany and Europe looking at the cost of reintervention for endovascular femoral popliteal procedures. A reintervention for a blocked stent in the FemPop segment costs 20,000 euros. So that's far more expensive than any endovascular device. So if an endovascular device can prevent that reintervention, then I will consider using that regardless of how expensive it is.
So I want to ask you these three amazing questions, which are for 3 different series that we have. The first one is for our Journey to Diagnosis series, and I want you to share a case that you had that just had you scratching your head about how in the world could this patient have not been diagnosed sooner, and what would you have wished would have happened differently with that patient. Now, you could also take it in another direction where you've had a patient come your way with all kinds of other procedures, which may have included a spinal fusion, and all they should have been diagnosed with was P.A.D., and they would have never needed these other procedures.
Well, I would probably share a recent case, a lady who kept being told that the 3 small ulcers that she had at the level of her 1 foot were due to a burn that she had sustained before. She did have diabetes and some neuropathy, which is common in diabetes, but unfortunately, no one had examined her foot and her leg in terms of looking for pulses in the community. So her journey to diagnosis was quite delayed, really. Only turned up to clinic about 11, 12 months after she first spotted those ulcers. By that time, she had suffered with a number of infections, given some antibiotics by primary care, going back and forth. Eventually, someone examines her for pulses and ends up in one of our clinics, and then had a number of endovascular procedures and then a common femoral endarterectomy after 6 months. Unfortunately, ending up eventually with a below-knee amputation. Interestingly, we've published an article. Our team in Leicester published an article about 2 or 3 years ago looking at how many times people in England see their GP before they get diagnosed with chronic limb-threatening ischemia, and that's 19 times. So people have to go to their GP 19 times for someone to check their legs for pulses and diagnose CLTI.
That is shocking. And so
Yep.
that is something you're definitely hoping is going to change, and you're hoping for a policy change to make that the difference there.
It's not just policy change, it's awareness. We just need to understand that P.A.D. is becoming far more prevalent with the rising prevalence of diabetes and obesity. And we need to train healthcare professionals a bit better in the immediate future.
So for the Pulse series, now share a case with a big lesson for you and others. Describe the patient, the frustration with the case, and the lesson that you learned and others can learn from it. It could be a success, it could be a failure, it could have included a little bit of ingenuity on your part. Can you share a case?
Absolutely. There is this patient that I have been seeing for about 4.5 years now. Initially diagnosed with claudication, very keen to have an endovascular procedure at the time because best medical therapy had failed. Then the patient had femoral popliteal disease, so a blockage of the main artery in the thigh with some disease of the artery behind the knee called the popliteal artery. I was convinced to do an endovascular procedure. Then, unfortunately, the patient has come back for about 7 or 8 re-interventions in the meantime. Not very old, I would say, let's say early 70s, let's put it there. Several re-interventions. Her stents have blocked 2 or 3 times now, opened them up with atherectomy, eventually ending up with common femoral artery endarterectomy, and following that, another intervention and subsequently needing a bypass. So a couple of lessons from me there. I think, first of all, best medical therapy and exercise is extremely important in people who claudicate. And I most definitely do not offer interventions now to people who claudicate unless they've tried some decent exercise for a few months. Mm-hmm. And the second thing, we discussed this a couple of times during our chat before, bypasses and endovascular procedures. Well, sometimes bypasses are far more durable than redoing an endovascular procedure 5 or 6 or 10 times. And in fact, a more invasive procedure at baseline for certain patients might be the right choice. So I'm far more open-minded now about doing bypasses for the right patient.
And that's what your research is about, is trying to figure out who is the right patient.
Absolutely, yeah.
And my final question is 6 minutes. We have a 6 minutes that mattered series. I love this series because I get to learn so much more about, who you are. But share 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a specific direction in your career. It could be a conversation you had with someone. It could have been a scene in a show, a movie, a documentary. It could be something you witnessed, something eye-opening. What are the 6 minutes that mattered in your career?
Yeah, it's an interesting question. Let me share something clinical then. Starting as a consultant, so that means as an independent practitioner, to put it in American terms. A few years ago now, one of my first cases, complex iliac disease with long blockages in the iliac arteries on the one side and some narrowings on the other side. Decided to offer an endovascular procedure, spent about 20, 30 minutes to cross the occluded iliac artery. Then, whilst performing an angioplasty, trying to push a stent up the way, actually, the patient suffered a rupture of their iliac artery. And it was a very interesting 6 minutes, to put it that way. Because essentially we couldn't push any stents up the way, and that means that you can't stop the bleeding very quickly. Anyway, the patient did absolutely fine in the end. We managed to save the day through various maneuvers and using the right wires in the end. The patient is doing fine, even now 5 or 6 years after the procedure. And this is partly what led me to apply for funding and seek funding for the EVOQUE trial that we discussed earlier, looking at whether open or endovascular procedures might be better for these very complex aortoiliac lesions. We wouldn't be here randomizing and recruiting patients for this study if it wasn't for those few minutes where seriously, the situation in the operating theater, was not very pleasant, to put it nicely.
Yeah. Oh my gosh. And I'm sure Dr. John, you could relate with a defining moment like that.
Oh gosh. I mean, I've got a lot of clinical ones, but I remember when I went to train with Marco Manzi for a week, it really opened my eyes as to what can be done in the tibial vessels. And we were doing a case, and he had said failure's not an option. And I think that's always stuck with me. There's a fine line between pushing the envelope and being too aggressive and putting that patient at risk. But there's also I call it my spidey senses, but there's also that like sixth sense that gets into your head and tells you, I think I can push this, or maybe I shouldn't. And I always tell people, listen to that voice in your head that's saying, go for it or pull back, because it typically is telling you to do the right thing. And that's always stuck with me. Failure's not an option, but listen to the whatever you want to call it, my spidey sense or my sixth sense.
And I see Dr. Saratzis nodding. You agree too, huh?
I couldn't agree more. I had a similar conversation this morning. I don't think what we do will ever be replaced by AI or whatever you want to call that, because there's that weird sense that you get when you're operating, or even when you're doing a ward round and you're seeing a patient or in clinic, and you kind of know when to stop or why you need to stop. And you can't really explain that very easily. It only comes with experience. And that's why I think trainees need to be in the operating theatre for far longer hours than what they're currently spending in theatre, at least in the UK.
It's that really scares me, the limited time that our we have residents and the work hour restrictions and the fact that they don't stay overnight, and there's all sorts of stuff. But it's like and I always say this, it's the Malcolm Gladwell's 10,000 hours. The Beatles just didn't show up in the US and know how to play. They practiced hours and hours and hours and hours and hours and hours, and that's what we have to do. And that's what kind of scares me. But yeah, Thanos, to your point, you can't explain it, and that's why I agree. You can never replace what we do with a robot, because there's just something, and I don't know what it is, but there's something.
Absolutely. You don't just open up a tibial artery. There's far, far more to it, really. Yeah.
Mm-hmm. Which is cool.
Absolutely,
it's
yeah.
interesting, because I hear you both talking, and it's something that Dr. John has heard before. But again, those who are watching and the patients in our network especially always hear me say that, I've been traveling the world since 2016, watching hundreds of doctors, thousands of hours of procedures across England, London, Italy, Germany, the US, all across everywhere. And the one commonality between all of the most advanced limb savers, such as yourselves, is that spidey sense, is that innate sense that you have that to do almost the impossible, what others would deem is impossible. It's like you see these people in their wellness suddenly, and you're able to reverse engineer it. But conversely, you're also able to say when to say when, right? And it's just, you can't explain it. It's just there.
As a P.A.D. patient, I think it's fascinating because in the last couple of months, we've been hearing a lot of people, y'all doctors and your researchers, going to the very beginning instead of somewhere in the middle or in the end now. So I think there's a lot of starting to understand better. We need to do something before we get to this point. Mm-hmm. And we need to focus on that a little more now than halfway through the procedure or all the way through. I hope that, you know what I'm saying? Instead of waiting till you have a flat tire, take care of the tire. Instead of running out of gas, you pump gas, that type of stuff. And for your experience, I have to tell y'all, don't ever deny that little instinct inside your head, Dr. Phillips. Don't ever deny that, because you're absolutely true. I'm a recovering addict, 39 years in recovery, been a counselor for 30 years. I have learned when to and what direction to go and what direction not to go when I'm sitting in front of somebody. You have to rely on that experience, and that's why you do what you do. and as good as you are, is that you do think about that. But I do find it fascinating that we're getting to that, or we're starting. I think the patients that are coming behind us are going to appreciate that more than what we did.
Mhm.
Absolutely. And that is like you said with the bypasses, I know I have the axial. I know I'm going to be okay. I just know everything's going to work out. I know it. But I keep hearing, well, 5 years, 3 years, 5 years is all they usually last. So I still think about that. But with the research and what we're learning now, I think as a patient, that's exciting for me to hear what you're doing, and you're making the advances. And we want, as patients, we want all our doctors to know about this now. Let's get the word out there. Let's just let me show up with the doctor and say, here's the research. Why are you going to do this bypass and not this procedure?
Yeah, first of all, I couldn't agree more with regards to what patients do before and after these procedures. Medical optimization is far more important than any revascularization procedure, both before, medical optimization before and after these procedures. And also, we need to understand what we mean by medical optimization. It's not just one more tablet. It's things like looking after people's mental health, looking after their lifestyle changes, their diet, etc. So we do forget about all of those things. These are extremely important. And then when it comes to research, again, I think we need to understand that we have to help patients understand why taking part in those studies is important, again, both before as well as during and after those procedures.
I really appreciate all the time, Dr. Saratzis, that you've spent with us today. We really appreciate you, answering so many questions and for, again, exemplifying exactly why you are so deserving of this award. You're really driving, research that has a potential global impact. And I think so much of what you've done already has had a profound impact on, doctors across the globe and policy as well. I'd like to see your research in the next set of guidelines for the ESVS that they're, I guess, working on right now. I'd like to see more of your current research be reflected in the next set of guidelines that I know that they're getting ready to work on.
Excellent. Again, thank you so much for the award and the invitation today, and very nice speaking to you. I hope I've provided some insights with regards to what we're doing over here.
Thank you so much, Dr. Athanasios Saratzis. We really appreciate you, our global Vascular Luminary of the Year for 2024 through the Global P.A.D. Association. This entire conversation exemplifies why you deserve this honor.
You've been listening
Thank you
to
for everything
The
you
Heart
do for
of Innovation
patients.
with Emmy
Thank you.
Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.